Good morning. My name is Eimear Cleary. I'm a research fellow with the World Pop group at the University of Southampton. And this morning I'm going to be presenting some work that was carried out by colleagues at the Jiangxi Normal University and World Pop in collaboration with different researchers in different institutes. And I'll be presenting on behalf of Shenji Lai, who wasn't able to make it here today. How do I go forward? There we go. So in recent decades, we've seen emergence of different infectious diseases, some of which have escalated to epidemics and pandemics like H1N1, Zika, and COVID-19. And early identification of infections and populations at higher risk of infection is crucial in the early stages of a pandemic in order to prevent onward transmission and contain infections. And a lot of the strategies that are commonly used, like passive surveillance or random sampling of populations, might be inadequate. With passive sampling, you'd miss a lot of asymptomatic cases, and people may already be infectious by the time they present for testing. Random sampling is costly and logistically and time intensive. So in infections that are transmitted by human-to-human transmission, transmission is linked often to variations in human behavior, such as mobility and visits to locations of interest. But this kind of spatiotemporal data is rarely incorporated into a modeling framework in order to identify high-risk populations to target screening. So the aim of this work was to develop a spatial sampling framework using human mobility and infection data in order to optimize citywide screening, so to detect infections and populations that are at higher risk of infection in order to target sampling and testing of populations. So a couple of different data sources were used to develop these mobility-based spatial sampling frameworks. Infection data was obtained for 2 cities in China, Guangzhou and Beijing, and case numbers and affected communities, so communities where infection had been detected, were obtained from daily epidemic notification reports that were compiled by the Beijing and Guangzhou Municipal Health Commissions. Point of interest data was derived from AMAP services, which is a car navigation system. So point of interest data is aggregate data that measures the number of visits to locations of interest within a community. And these places of interest are aggregated according to a specific category. So for example, a visit to a supermarket or a tourist attraction or a healthcare facility or a religious centre. And mobility data was obtained from China Mobile, and this mobility data was hourly 2-day population movement flows between communities in Guangzhou and Beijing. Population density data was obtained from World Pop, and these data were used to analyze individual movement patterns and contact intensity within communities in order to estimate community level infection risk. So as infection might differ depending on mobility patterns and contact intensity, 4 different mobility-based spatial sampling frameworks were developed. So human contact intensity explored the interpersonal interaction within a community, and it was based on the number and categories of places of interest visited within each community. Human flow intensity identified infection risk caused by people entering and leaving a community. So this was defined by overall counts of inflow and outflow based on mobility data in communities, with larger population flows indicating higher contact, human contact and infection risk. Case flow intensity identified higher infection risk within communities visited by more cases. So this is derived from counts of initial confirmed cases and inter-community movement. So this approach identified communities which had an initial confirmed infection and explored then movement to and from these communities where infection had been detected. And this was derived from case and mobility data. And case transmission intensity identified communities where individuals were more likely to be infected. So this was based on counts of potential new infections caused by identified infections within communities, and it was derived from infection and point of interest data. So these approaches were used to determine a sampling priority, which was based on the community level infection risk due to COVID-19 transmission. And it specified the number of communities to be sampled each day. So it identified communities at higher risk of infection and therefore higher risk of onward transmission for targeting sampling and testing. And more resources were then to be allocated to sample communities than those not sampled. And the accuracy of each of these approaches in identifying infections and discerning affected communities was assessed using the trade-off between accuracy of infections detected and the volume of tests required at different sample sizes. So the perfect sampling approach would be one in which all infections were detected using a sample size equivalent to the number of cases or affected communities, or the point with the least geometric distance to the upper left-hand corner of the curve. And this represents the most balanced compromise between test accuracy and volume. These approaches were also compared under different outbreak and data scenarios, so different R0, different population densities and timing of interventions. These four approaches were compared with just simple random sampling, where each community had an equal chance of being sampled. And finally, the spatial sampling frameworks were incorporated into an SEIR model to simulate disease testing under multi-rounds of mass testing. So what this research found was that using infection case data and mobility data identified infections and affected communities with greater accuracy, particularly in the early stages of a pandemic. So compared to citywide screening and simple random sampling, the case flow intensity and case transmission intensity approaches were superior at identifying infection risk within communities. So for example, in Guangzhou, the case flow intensity spatial sampling approach identified 78.5% of affected communities using a 17.9% population sample, and in Beijing, 84.1% of affected communities were identified using a 21.1% population sample. Compared with simple random sampling, these approaches that used infection and mobility data outperformed models in terms of spatial coverage and quantity. And what my colleagues found was that these approaches were more effective at identifying infections and affected communities during the early stages of the pandemic in populations that had a lower density, where there was fewer source communities and with a lower R0. And accuracy of these approaches declined as the outbreak spread across communities. And finally, compared to a baseline approach of multi-round testing using an SEIR model and simple random sampling, these approaches using infection and mobility data were superior at earlier detection and containment of transmission. Particularly, you can see with the higher R0, when interventions were implemented earlier, these approaches were superior at identifying infections and affected communities, which suggests that using these approaches can result in earlier detection of infections and containment if it's used early on in the pandemic, and particularly with highly transmissible variants of COVID-19. So in summary, these approaches using infection data had enhanced accuracy at identifying infections and communities at higher risk of infection compared with just a standard SEIR model, with the approaches, spatial sampling approaches using just mobility data and using simple random sampling where all communities had an equal chance of being sampled. And the standard SEIR model had good accuracy also in identifying infections and affected communities, but they're complex and reliant on various epidemiological assumptions and parameters, whereas the CFI and CTI approaches relied on fewer epidemiological assumptions. The component that stood out most from these approaches was that infection risk was a crucial element of detecting infections and affected communities caused by mobility in the early stages of a pandemic. And implementing these approaches early was shown to improve effectiveness of testing and identifying high-risk populations for earlier identification of high-risk communities and containment of transmission. But in highly populated areas, the effectiveness might decrease, and effectiveness of these approaches decreased as the geographic extent of transmission increased as well. So the major take-home message from this work was that if these approaches using infection data and mobility data are implemented early on in the pandemic, they can be very effective at identifying communities for targeting sampling and testing, and this in turn would minimize infections and onward transmission to other communities. Thank you.